Why does my arm hurt? From little leaguers to golden sneakers. This is a case-based approach. My name is Mary Lloyd Ireland. I'm a professor at the University of Kentucky, orthopedic surgeon. This was presented at the Sports Medicine Essentials course through American College of Sports Medicine, formerly the Team Physician course. This will be our menu. We'll start with the elbow, then go to shoulder, and then go to conclusions. There will be a time code to tell you where each of these will be in the presentation. What about shoulder injuries? In the adolescent, there are no good epidemiologic studies. There are trends toward acute dislocations in defensive players in football, in extreme sports such as skateboarding, diving, other things such as winter sports now with snowboarding and other events that have become popular in the Olympics. Thinking about the contributions of the arm in that skeletal immature, contributions of individual growth. On the right, you can see the percentage of each bone. So in the humerus, what we see is 80% of the growth of the humerus occurs proximally, 20% at the elbow. When we think about the forearm, it's opposite. 80% of the growth occurs at the distal radius and 20% at the elbow. Thinking about the entire extremity, 80% occurs at the proximal humerus or the distal radius. So 40% proximal humerus, 40% distal radius, and then 10 distal humerus, 10 proximal forearm. They're not complications or problems from a short limb, but sometimes you do need to counsel the patients and family that x-rays need to be done and follow up to see the length of the limb. Appearance and closure of secondary ossification centers like the elbow, they're varied. It's important to know the males and the females. The appearance is here with the males in M and females in F, and then here are the closures. Again, a comparison view may be very helpful to determine any asymmetry one side compared to the other and help you find a fracture. Appearance and closure of the secondary ossification centers of the scapula, coracoid, acromion, clavicle. The last closure is of the medial clavicle at age 25. You can also see some apophyses in the coracoid. I've seen a few fractures of the coracoid through this apophysis. They heal, but you need to make the diagnosis and keep them out of contact sports. An os acromial is a non-fused os. Won't really be able to make that diagnosis until the early 20s when that should have fused. Usually asymptomatic. Seen best on an axillary lateral view or a striker view. This is a 16-year-old who had a medial epiphyseal fracture of his clavicle. He wasn't really dislocated his sternoclavicular joint, but you can see the prominences of the medial clavicle on the right. Significant structures that can be injured if there's a posterior dislocation or if we do surgery. It's very difficult to stabilize the saddle joint. Diagnosis is made by physical exam. You can get a plain x-ray. A CT scan gives us better information about appearance of that medial aspect of the clavicle. Hard to get a lateral view, plain view, because it's difficult to get rid of the head. And then this 3D shows this fracture. This is treated with symptomatic, with a figure of 8 if they would like that, sleeping with a pillow behind their scapula. And here he is 1 year post-op. He never went back to football. He does have this cosmetic deformity, but no functional problems. Little leaguer's shoulder, by definition, is a proximal humerus stress fracture. The patients present with diffuse shoulder pain. Usually it's reproducible when trying to do a throwing movement, such as with external rotation, and they hurt in the proximal humerus, oftentimes more posterolateral and with external rotation. They may not be weak in their rotator cuff. Radiographs are done. Comparison striker views usually show asymmetry, and you can make this diagnosis with plain films. Typically don't need an MRI scan. This is an example on the bottom of little leaguer's shoulder. You can see on the right shoulder, on the left-hand side, there is a greater distance here, greater radiolucency from the humeral epiphysis to the metaphysis. So this is a Salter 1 fracture of the proximal humerus. And you can see the opposite side. So when you're making this diagnosis, it's oftentimes good to get a picture of the opposite side. That gets the parents and the individual to know it's going to take a while for this to heal, and they just can't throw. If they're really symptomatic, you can put them in a sling, but usually they're not that symptomatic when you stop external rotation forces such as in throwing. The epiphysis usually has a little bit more of a line here laterally, so that's normal on this side. And you can see how the bone is already starting to heal. We see this in gymnasts, the distal radius, where the distal radius has extra compression forces, and this may cause a arrest of the distal radius and a relative overgrowth of the ulna. So be aware of that and get plain films if there is distal radius wrist pain in a gymnast and somebody that's doing repetitive axial loading. Little leaguer shoulder in this series by Bill Carson. There were 23 patients in the Florida area. Average age was 14. 19 of the 23 were pitchers. They had pain while throwing. Usually they had pain for about 7 months before they were seen. In the treatment, this will heal as long as you don't allow them to throw. Usually it heals in about 3 months. The follow-up was 10 months. And most of these individuals return to baseball. Typically it's pitchers. There could be some rotation at that epiphysis that accounts for the increased external rotation in the dominant hand of pitchers that we see in pitchers who have started pitching when they were skeletally mature. So there could be a skiffy type rotation of the humeral epiphysis on the diaphysis, accounting for bony adaptation and what we see with the skeletally mature pitcher. This physeal and range of motion changes in a study by Scott Mayer and Tim Uhl from the University of Kentucky. There were 79 youth baseball players, ages 8 to 15, and there was increased physeal width on the dominant side and also increased external rotation on the dominant side. There were some CT scans that were done to confirm an asymmetry in that proximal humeral epiphysis, consistent with some rotatory abnormality with the way that the little leaguer's shoulder healed. This is a biomechanics magazine that's also talks about rotational adaptation and humeral head external rotation or retroversion that occurs in throwing athletes. This is a 15-year-old baseball outfielder. He just threw the ball from the outfield, felt acute pain in his arm. It was like his arm followed the ball to the plate. And you can see his diaphyseal fracture. The initial x-ray is on the left, and you can see a little suggestion of maybe there is more lucency here. So if you see this injury with very little trauma other than throwing, think about an underlying pathologic fracture, and in this individual, it was a simple cyst. It can be a little hard if you see them when they already have a sugar tongue on or plaster. So this is at 6 weeks. And then this is at 2.5 months, so it will heal. It might heal more predictably after a fracture occurs. So this is a pathologic fracture through a simple cyst of the diaphysis. You can see here where at 2.5 months it's filling in. This was a 12.5-year-old who broke her left wrist, and she was told not to do crazy things, but she went and did some log dancing in a river and fell and broke her opposite humerus. So she has a right humerus fracture. And in her, it's a little hard to see the cyst, but she fell onto the bank and Didn't do anything bad to her opposite wrist fracture, but she was probably a little off balance, and she has a fracture through a simple cyst of her humerus. And you can see it's a little more concerning in her situation. She wants to get back to play soccer, and she still does have a pretty significant cyst here. And at 18 months, she's totally asymptomatic, playing full sports, not doing heavy lifting like bench press or a axial loading sport such as gymnastics. But she goes ahead and heals this. This is at 3 years. I got an x-ray when I saw her for another orthopedic problem. So think about a simple cyst if there is not a lot of trauma and a fracture of the humerus diaphyseal. Remember to examine the scapula. Have the patient reproduce their symptoms. They may come in with shoulder pain, and you need to get the females in a sports bra or a tank top, and the males examine them without their shirt on, because you may think it's a shoulder problem, and it is not a rotator cuff or a glenohumeral problem, but it is more of a scapular problem. If the scapula is unstable, shoulder problems will result. And an unstable scapula is similar to firing a cannon out of a canoe. It just doesn't work well, not effective. The cannonball doesn't go far. Scapular dysfunction. Remember the scapula. You can have tightness anterior of the shoulder. The head can be forward. You can have overdeveloped pectoralis. This all affects the scapula. The scapula may have been abnormal to start off with. What we do to try to improve scapular position is the command of putting their elbows in their back pocket, touching the medial borders of the scapula, doing shrugs. Think of the scapula as a clock face, moving counterclockwise and clockwise. A lot of different muscles act around the scapula. The protractors and retractors. Typically what happens when there is scapular dysfunction is the scapula moves in a protracted way and upward. This happens because the glenoid, which is the socket of our shoulder, is also connected, obviously, to the humerus. And so there are adaptations that most likely come after the shoulder injury, where the scapula typically moves up and in a protracted. So it goes upward and then protracts, and that's probably a result of a rotator cuff problem or an instability problem, an adaptation trying to get the glenoid in a little better position. So when you have somebody abduct their arms, sometimes you may think that glenohumeral movement is normal, but a lot of it may be at the scapulothoracic articulation. So a lot of different muscles here, rhomboid, serratus, latissimus, causing the movement of the scapula. This is an individual who was doing 20-pound single leg dumbbells, doing forward punches, abduction, and if you look at his right scapula, there is asymmetry where there is a hollow or concavity over the area where his supraspinatus and infraspinatus are. He comes in with shoulder pain. If we hadn't taken his shirt off and examined his scapula, we probably would have made the diagnosis of rotator cuff strain, but that didn't really make sense. So see the asymmetry that he's got? He's really pretty strong in his supra and infraspinatus, but when we do rotation, you can see the scapula moving, like we talked about, more in a protracted upward position. He can do dips, but there's a definite asymmetry where there is not the normal muscularity here, indicating a neurologic injury. So he had a brachial plexus stretch of a C5 injury from up in his neck, causing atrophy here of his muscle. It wasn't a rotator cuff tear, it was atrophy because of a stretch of the C5 musculature, which innervates the supra and infraspinatus. Relative rest worked for him. This is a golfer, right-handed, who was having left shoulder pain. He had had a slap repair done 5 years before of his left shoulder. The thought was maybe he had had a new injury to his labrum. And when we asked him to do his golf move, which caused him to have pain, you can see the asymmetry of his scapula. See how it wings? But he doesn't have that atrophy as in that last individual that had the C5 radiculopathy. And ask him to do the activity. He doesn't have a golf club, but you can see here where there's asymmetry of his scapula, which is primary problem. Oftentimes that's compensatory for a shoulder problem. And when you do hands on the waist and push back, there's not a difference. But when he does his golf pretending to hit, there's a definite difference. Scapular retraining worked for him, and he really didn't have a primary glenohumeral joint problem. Oftentimes the scapula, again, occurs secondary to a shoulder problem. But remember the scapula and always examine it. Again, it's like firing a cannon out of a canoe. If your scapula is unstable, you're not going to be able to get that cannonball too far. This is a 20-year-old left-hand dominant individual, had true scapular winging, if you will, because of a solid mass. He has multiple osteochondromatosis and did have a scapula osteochondroma. His girlfriend had noticed this when there was an asymmetry in his scapula. X-rays clearly show this osteochondroma. Because it was central in this area, there was concern that it could have a malignant degeneration, so excision of this was done. So get an X-ray, look at the X-ray, look at the scapula. This is a good scapular Y view that well shows this mass. Fortunately, it was benign. In this axillary lateral view, which is a great view, coracoid is anterior. So here's the glenoid, here's the coracoid, and in the back is this mass. CT scan is helpful in these cases, and this showed a mass that had been there for quite some time. Sometimes it's hard to see your scapula and see what's going on with it, so it's always good to have someone look to see if there's symmetry to the scapula. Adults are obsolete children, Dr. Seuss. So in this presentation, from our young athletes to our older athletes, I've tried to show you what things to use to make the correct diagnosis. In our older golden sneaker athletes, you need to make sure they have a realistic expectation of their shoulder arthroplasty and make sure that you've gone through all other options before referring them for arthroplasty surgery. Thank you very much.